Hi, welcome to Topic 4, Part 1. In this screencast, we're going to be talking about disorders of white blood cells. Let's start with a little bit of review of blood cells. All of the formed elements in the blood arise from the same stem cell, and it can follow one of two pathways: the lymphoid pathway, which is going to make the lymphocytes, NK cells, T cells, and B cells, which differentiate into plasma cells, or the myeloid pathway, which makes all the other formed elements. Also, white blood cells include the monocytes, and then the granulocytes, eosinophils, neutrophils, and basophils. And then from the myeloid pathway, we have the megakaryocyte, which fragments break off of that to become platelets, and then the erythrocytes, or red blood cells. Okay, here are the the learning objectives for the disorders of the leukocytes, or white blood cells. So the leukocytes, they are the only complete cells within the blood. They have a nucleus and organelles, unlike platelets and red blood cells. They are crucial to the defense against disease. They don't last very long in the bloodstream, but they migrate into the dense connective tissue and lymphoid tissues. So there's three main types, three main pathways: the granular leukocytes, the monocytes, and the lymphocytes. So the granulocytes contain cytoplasmic granules, and these include the neutrophils, which are the most numerous of them all, and they're the main pathogen or fighting cells. They're especially important for phagocytosis of bacteria. The eosinophils, these are involved in fighting parasites and in controlling allergic responses. And then the basophils, these are what differentiate into mast cells in the tissues. So like a mast cell, they release histamine and heparin and other inflammatory mediators. And then we have the monocytes. These are the largest of the white blood cells, and they're involved in inflammation and phagocytosis. So when monocytes leave the bloodstream, they become the macrophage. And macrophages also act as antigen-presenting cells. And then the lymphocytes, there are three different types. The part involved in immunity are the B cells and the T cells. Remember, the B cells differentiate in plasma cells and create antibodies. And then the T cells, which can differentiate into helper T cells or suppressor T cells or cytotoxic T cells. So these are involved in specific immune defenses. And then we have the natural killer cells, which act non-specifically to kill antigenic cells. Okay, white blood cell deficiencies. Leukopenia refers to a decrease in the absolute number of leukocytes in the blood. Neutropenia, also called agranulocytosis, because the neutrophils are the most numerous of the granulocytes. In fact, they're the most numerous of all the white blood cells. So if these are low, less than 1,500 per microliter, this is called agranulocytosis. This can be caused congenitally due to a viral infection, bone marrow depression due to like chemotherapy, radiation, or other drugs such as benzene. White blood cell deficiencies can lead to skin infections, lesions of the mouth, but can also lead to severe bacterial infections and death. Aplastic anemia is an abnormal reduction in all the formed elements of the blood. So this is going to result in leukopenia, thrombocytopenia, and anemia. Infectious mononucleosis. This is a viral infection that specifically attacks B lymphocytes. And then HIV, as we talked about in Topic 3, is a viral infection that results in deficiency of helper T cells. The leukemias are a group of cancerous disorders that involve white blood cells. Here, these white blood cells divide uncontrollably in the bone or in the lymph nodes. These leukocytes are undifferentiated, immature, and non-functional. Large numbers of these non-functional white blood cells can then get released into the general circulation, infiltrating the lymph nodes, the spleen, the liver, the brain, and other organs. They also replace the bone marrow, and this can lead to a lot of bone pain and bone erosion. and they get released as immature or non-functional white blood cells into the blood. What type of leukemia you have is classified based on the predominant malignant cell type and whether it is an acute or chronic condition. Okay, so it could be classified on the cell type, progenitor cell type. So lymphocytic would be from this pathway, or myelogenous would be from the myeloid pathway. We can also compare leukemia as being acute or chronic. Acute leukemias, which include acute lymphocytic leukemia and acute myelogenous leukemia, have a high proportion of very immature and non-functional white blood cells. These are referred to as blast cells. Blast cells are non-differentiated and they're not functional, so they don't act like a normal white blood cell, so they're useless in fighting infection. The onset is abrupt and the signs are marked, and there are many complications related to depression of the bone marrow and the lack of functional white blood cells. So even though there's lots of white blood cells in the blood, they're not functional. Chronic leukemia, we have a higher proportion of mature cells. So these are more differentiated and more functional. So we have fewer non-functional cells in chronic leukemia. It develops slowly with an insidious onset. The signs are more mild and the patients have a better prognosis. Acute lymphocytic leukemia is the most common form of childhood leukemia, accounting for about 75% of the cases. Most cases involve immature precursor B lymphocytes. About 90% of these patients have changes in their chromosomes, usually due to translocations, that leads to abnormal expression of transcription factors that are needed for normal blood cell development. It's thought to be caused by a genetic predisposition or exposure to chemical and radiation. These are all things that are related to the development of ALL. Because it's acute, it is a rapid in onset with more marked symptoms, signs and symptoms. Acute lymphocytic leukemia presents with very large numbers of non-functional lymphocytes in the bone marrow and as well in the blood. So we can see a bunch of these white blood cells, lymphocytes, in the blood. This is going to cause increased pressure and expansion of the bone marrow. One of the common signs is bone pain and bone tenderness. And as I mentioned, we have a high percentage of these blast cells in the blood, and the patients have multiple infections. Additionally, the expansion of the bone marrow by all these leukemic cells crowds out the other cells and reduces their production. So this can result in decreases in red blood cells, which would lead to anemia, and then signs associated with anemia such as fatigue, weakness, and poor wound healing. We're also going to see a decreased number of platelets or thrombocytopenia, and this can lead to bleeding, bruising, and even hemorrhage. Acute myelogenous leukemia, this affects primarily older adults, but can also be found in children. In fact, it's the second most common cause of childhood cancer. Also affects young adults. And this results from an abnormal proliferation of cells from the myeloid stem cell pathway. Once again, it's acute leukemia, so we get large production of myeloid blast cells. This is also usually due to genetic alterations, and these are such that inhibit the differentiation of the myeloid cells. It can also be caused by chemicals such as benzene or formaldehyde. Can also be caused by chemotherapy or radiation. So once again, bone marrow elements get replaced with the undifferentiated blast cells, and that suppresses the remaining progenitors' stem cells, and that can lead to anemia, neutropenia, and thrombocytopenia. Because it's acute, we have a rapid onset and course of disease. So you should take a few minutes to jot down the reasons behind the following manifestations of acute leukemia, but I'll go through these now. So multiple infections. So these are going to be multiple infections that are often resistant to treatment. And this is going to be due to a deficit of normal white blood cells. Now remember, we have large percentage of blast cells, but these are unfunctional. Anemia signs. This is going to be due to depression of red blood cell production. Bleeding and bruising. This is going to be due to reduced production of platelets. Okay, remember the bone crowding, the bone marrow crowding is going to lead to not only decreased normal white blood cells, but also decreased red blood cells and decreased platelets. Fatigue and weight loss are going to be due to the rapid proliferation and metabolism of leukemic cells, as well as anorexia from infection, pain, and as a result of treatment, potentially with chemotherapy. Fever would be due to the hypermetabolism and multiple infections. Bone pain and tenderness is going to be due to bone marrow expansion due to all the leukemic cells. Swollen lymph nodes, swollen spleen, and swollen liver is going to be due to infiltration of leukemic cells. This is going to be more common in the ALL. Same with CNS involvement. This is going to be due to infiltration of leukemic cells across the blood-brain barrier, and this is going to be more common in ALL. Leukostasis, this is a markedly elevated blast cell count. And hyperuricemia, this is a high amount of uric acid in the blood, and this is due to the breakdown of purine nucleotides in these leukemic cells. Chronic lymphocytic leukemia makes up about 1/3 of all leukemias, and it is the most common adult form of leukemia. So it affects mainly older adults. Average age of diagnosis is about 72. It's usually not seen in children or in people under the age of 40. It's usually from a B cell origin. So there's kind of two different diseases based on the aggressiveness of the disease. That's thought to be due to differences in expression of cell surface markers. So the indolent form, this is largely asymptomatic at diagnosis and is often found just during routine blood work. People survive for years and usually die of unrelated causes. So the only real cause is a high, or the only real sign being a high white blood cell count. The aggressive form causes severe swollen lymph nodes, swollen liver, fever, abdominal pain, weight loss, anemia, thrombocytopenia, and a really high lymphocyte count. So the diagnostic hallmark is an isolated increase in white blood cells of greater than 20,000 per microliter, which could be up to several 100,000, and 75 to 98% of them being lymphocytes. Normally lymphocytes only account for about 25% of the white blood cells. Chronic myelogenous leukemia accounts for about 10 to 15% of all leukemias, and it affects mainly older adults, with the average age of diagnosis being about 67 years. It results in excessive proliferation of granulocytes, erythroid precursors, and megakaryocytes. These all come from the myeloid pathway. It's thought to be caused when one of these stem cells acquires what they call the Philadelphia chromosome abnormality. This is present in about 90% of patients, and this is due to a chromosomal translocation. There's a triphasic course of the disease. The chronic phase, we have an elevated white blood cell count with weakness and fatigue, and this progresses to anemia and thrombocytopenia in about 4 years unless there's effective treatment. The accelerated phase involves enlargement of the spleen, progressing symptoms, weight loss, and bleeding, and that lasts about 6 to 12 months. The terminal or blast crisis phase is where it kind of turns into an acute leukemia, and we get a huge proportion of blast cells of greater than 100,000 cells per microliter. Really prominent or marked signs and a poor prognosis of about 3 months. The lymphomas involve solid tumors in the lymph nodes, solid tumors of lymphocytes in the lymph nodes. There's not a specific cause that has been identified, and there are two main types, Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma, the usual age of onset is between 15 and 40 years of age, and then again after 55 years of age. Hodgkin's has a very great prognosis when localized, so when it's detected relatively early. It usually involves a single lymph node, and this is usually cervical, large and painless. And then this tends to spread in a contiguous fashion, meaning it would spread to neighboring lymph nodes in a continuous pathway. The T lymphocytes seem to be defective, and the lymphocyte count in the blood is decreased. One of the markers, if we do a biopsy, we see the presence of this Reed-Sternberg cell, which is this kind of really enlarged, funny-looking white blood cell. Cause is unknown, but it's been linked to carcinogen exposure, viruses, as well as some genetic and immune mechanisms. Okay, so the first indicator of Hodgkin's is that painless enlarged lymph node or group of nodes above the diaphragm, and it's usually cervical. Other manifestations include some mediastinal masses, chest discomfort with cough or dyspnea, fevers, chills, night sweats, and weight loss. Classic symptoms are pruritus or itching, intermittent fevers, and night sweats. Because of the decreased cell-mediated response due to decreased normal T cells, patients also have recurrent infections, and a decrease in cell-mediated responses called anergy, which is failure to develop a positive response to a skin test, such as the TB test, which you remember is mediated by a type 4 hypersensitivity reaction. Fatigue and anemia can occur as the disease spreads, and advanced stages include involvement of the liver, spleen, lungs, GI tract, and may include the central nervous system. Non-Hodgkin's lymphomas are much more common than Hodgkin's disease, and accounts for about 4% of cancers in the U.S. About 95% of the cases occur in adults, and most of these adults are over the age of 65, or at least half. There are over 30 different types, making up a very heterogeneous group of solid tumors expressed in lymphoid cells. So most of these are precursor B cells, some are T, or some are NK cells. The cause is not identified, but impairment of the immune system and infectious agents such as the Epstein-Barr virus and H. pylori may play a role in some of the types. But remember, there's a huge number of types. And they vary in aggressiveness and how the cancer may affect a patient's prognosis. However, the outlook is generally worse in non-Hodgkin's than with Hodgkin's. Okay, so with a non-Hodgkin's lymphoma, the Reed-Sternberg cells are not present, and non-Hodgkin's lymphoma involves multiple peripheral nodes, and they tend to spread in a non-contiguous fashion, kind of randomly throughout the body. The disease varies in severity. We have an indolent form, which we have kind of painless swollen lymph nodes, which is kind of disseminated, and that may transform into more aggressive forms. And then the aggressive form includes fever, night sweats, weight loss, increased susceptibility to infection, and this is due to low number of antibodies. Okay, on this slide, I'd like you to get out your pen and paper and do some writing. So you can use my talking, the screencast, or you can also use your book to compare and contrast non-Hodgkin's with Hodgkin's disease. So first of all, if we look at nodal involvement, in non-Hodgkin's disease, it involves multiple peripheral lymph nodes. In Hodgkin's disease, is usually localized to a single group of nodes, usually above the diaphragm. The spread in non-Hodgkin's is non-contiguous, while in Hodgkin is contiguous. Signs and symptoms of non-Hodgkin's include swollen lymph nodes, fever, night sweats, weight loss, increased susceptibility to infections. With Hodgkin's disease, signs and symptoms include enlarged lymph nodes above the diaphragm, cough, shortness of breath, fever, night sweats, weight loss, and itchy skin. Extranodal involvement in non-Hodgkin's disease is common. Okay, kind of can spread beyond the lymph nodes. With Hodgkin's, it is rare. Extent of disease in non-Hodgkin's, it is rarely localized. In Hodgkin's, it's usually localized. And then the Reed-Sternberg cell is not present in non-Hodgkin's disease, but is present in Hodgkin's disease. Burkitt lymphoma is a type of non-Hodgkin's lymphoma. It is a disorder of malignant B cells that usually begins in the jaw. There's 3 different types. The endemic variant occurs in Central Africa, and this is the most common cancer of children in this area. And it's usually associated with chronic malaria and previous exposure to a previous infection to Epstein-Barr virus. The sporadic type occurs outside of Africa and is usually not linked to Epstein-Barr. And then there's one that's immunodeficiency related, and this occurs often in HIV infection. Multiple myeloma involves malignant plasma cells in the bone marrow. And this is associated with abnormalities of the chromosome 14 involving the IgG locus. It's more common in older adults and African Americans and has a poor prognosis. These plasma cells are going to produce abnormal antibodies that are termed or called M proteins. Because we have a whole bunch of abnormal antibodies, but not very many functional antibodies, this is going to cause immune depression. These extra antibodies are going to increase the viscosity of the blood and can lead to deposits in the heart, kidney, and nervous system. Bence-Jones proteins refers to light chains of these antibodies that can damage the renal tubules and lead to kidney nephrosis. These malignant plasma cells erode the bone, and they're going to depress the production of other blood cells. So this can result in bone fractures and hypercalcemia, as the calcium is released from the bone into the blood, anemia due to the decreased red blood cells, thrombocytopenia due to the decreased platelets. It can also cause neutropenia, so decreased white blood cells. Other clinical manifestations include bone pain, which is the first symptom in about 75% of the patients, recurrent infections due to decreased neutrophils, weight loss, weakness, renal insufficiency, heart failure, and neurological impairment, and this is due to deposits of these proteins in these organs. Okay, you should take a look at this concept check and make sure that you can answer all these questions. And then take a look at the scenario about how leukemias affect bone marrow activity. How would they cause bone pain and the risk of fractures? How would they cause anemia? How would it cause bleeding and bruising or immune suppression? Abnormal white blood cells are produced and they release inflammatory mediators. So that could cause like fever. They release they infiltrate peripheral lymph node organs. Okay, so swollen lymph nodes, swollen spleen, swollen liver, increasing blood viscosity, increased blood pressure, create waste products. We're going to have high uric acid in the blood, and so forth. Tell whether the following statement is true or false. Hodgkin's lymphoma has a better prognosis than non-Hodgkin's. And this is true, because Hodgkin's is usually very localized, usually a single lymph node or group of nodes, usually cervical. Okay, that's it. We'll see you for part 2.